So thank you very much for the invitation, and you were not wrong. I am, in fact, the director of the Cancer Center, but also a practicing urologist. I've wanted to do cancer research ever since I was 10 years old. And turns out that I ended up being a urologist and doing bladder cancer, which is the focus of my research. And what I'm going to show you today is really a couple of vignettes of the type of research that I do. I think you'll get an idea of where the field is going with those vignettes, and there are going to be vignettes from my lab as well as other people's research. So I was going to use the handheld microphone, but so I can point, but maybe I can do it from here. I noticed the other speaker had a handheld. Okay, great. I don't think it's working. Oh, now it is. Thank you. Okay. Oh, with the slide projection. What is it? Is this the slide one? Yes. Okay. So before I start my talk, I would like to thank these two individuals. I think that had it not been for these two individuals, we wouldn't really be here. And this is Diane Qualley, who is the president of BCAN, and her husband, John Qualley, who unfortunately passed away because of bladder cancer. It is their energy, their vision, and their perseverance that really formed BCAN. And I think in the few years that BCAN has been around, it's been an enormous success, primarily because of their energy and vision. So I'd like to thank them. So there's been a tectonic shift in how we actually treat patients with cancer in the past, I would say, 10 years or so. And primarily that has occurred because of the evolution of medicine between being an empirical process that was, if you will, pioneered by Cyril M. Osler, who was one of the great physicians in the past. And I think the seminal comment that he made here, and I have it quoted, if it were not for the great variability among individuals, medicine might well be a science and not an art. Well, he realized even back then that somebody with tuberculosis could do fine and be chronically ill with it, and another person with the exact same disease could actually die from it. And he realized that the same disease could affect people differently. And but of course, back then, he didn't have the technology, the science, to really understand what is going on. So medicine was empirical, basically. There was tremendous heterogeneity, which is this variability among patients. And the doctors did what they could with a stethoscope and not much else. Now we moved on in the past a few years, I'd say 20 years, we practice currently what is called stratified medicine. So stratified medicine is really the medicine that we practice right now, the bulk of it. And stratified medicine is exemplified by this Kaplan-Meier curve. This is the type of curve that is very prevalent in medical journals, and I'm sure you may have seen this kind of graph. What it is that you start at time zero when the patient has a procedure or a treatment of some sort, and everybody is alive, or everybody is healthy, if you will. And in time, you basically have, this is the x-axis of the graph is time, you basically have patients in two groups based on some stratification, either how advanced the tumor is or another tumor characteristic. And then you can, if that characteristic is important, you basically have a divergence between patients with certain tumor characteristics and other tumor characteristics. So then what you say is, when you have a patient in front of you, you say, okay, Mr. Smith, your tumor has this particular feature, and you're likely going to be on this curve and not on this curve. Okay? So that's called stratified medicine, and we practice this today. But stratified medicine only tells you that you, Mr. Smith, are like 100 others that have this characteristics, and you have the X% chance of having some outcome or being disease-free at a certain point in time. That doesn't really tell you the risk for Mr. Smith. It tells you if you were 100 Mr. Smiths, you would have those odds. So that's called stratified medicine. But what's happening in the past few years, thanks to the genomic revolution that was pushed by Francis Collins and others, basically we have finished sequencing the genome, and so we know where all the genes are, we know the roadmap, and now we can study the genes that are changed in cancer, and that has allowed us to move to personalized or individual medicine, which means that we can analyze the tumor of Mr. Smith, and we can tell Mr. Smith exactly his chance of getting disease again, his chance of having tumor come back, and his chance of responding to the molecular-based therapies. These are drugs, these are smart drugs that can attack specific features of the tumor. So this is what I'm going to show you today. So the cornerstone of personalized medicine is biomarker development. So this is the genetic mutation, the overexpression of the gene that is altered in cancer. This is really the hallmark of personalized medicine. But if you look at all of personalized medicine and the ability to actually deploy this to patients, it's not just discovery biomarkers, which is what I do in my lab. We discover the machinery that is damaged in cancer. And so this is what I do in my lab, and that's what most scientists do. But some of us that are involved in medicine and in medical administration at the local and the national level are actually involved with some of these other parts of the deployment and implementation. And as you can imagine, getting a biomarker for a disease that predicts something basically has to go through various steps in order to actually get it to the patient. There's regulatory steps. The FDA is one such regulatory step that we have to deal with. There's healthcare delivery, and I'm going to show you an example of that from my own work where despite some science, or we actually invented some new science in order to help healthcare delivery, because the reality is that unless you make a compelling case for the new molecularly guided therapies of personalized medicine, the physicians in practice, which is the bulk of medicine in the United States, the bulk of healthcare delivery given in the United States are not by academics like myself. It's basically people in community practice, and we as academics owe it to them to make sure that we convince them of the value of these tools, because otherwise the question is, why should I do this test if it's not going to help my practice, if it's not going to help my patient? So this is really an important component. And then, of course, as you all know, money, the economics. So if something costs too much, then it's a trade-off between can it be implemented, will the insurance companies pay for it, et cetera. So it's a complicated wheel, but I think it's a fairly clear complication because we know what the steps are. So let me now show you what it is that when we talk about biomarkers or risk factors. I want to show you the way I think about this, which is basically developing or categorizing biological markers in 3 different groups. And I'm going to show you with this cartoon how they work. The 3 different groups are predisposition biomarkers, prognostic biomarkers, and predictive biomarkers. Predisposition biomarkers are basically clear. That's a marker that gives you the risk of getting cancer when you don't have cancer. So obviously, if one of those markers, and very simply put, if you're a smoker, you're going to have a higher chance of getting lung cancer, head and neck cancer, and bladder cancer. That's a marker. Smoking status is a marker, if you will, of getting a risk factor for getting bladder cancer. I'm going to show you other things, of course, at the molecular level. But that's a simple example. Prognostic markers. Prognostic markers are essentially a measure of how aggressive the disease is. So, simply put, you all are familiar with the concept of stage of the cancer. Stage is a classic prognostic biomarker. Predictive biomarkers. Okay, so that's a different type of marker because that is a marker that will predict the response to therapy. So a prognostic marker will tell you the tumor is aggressive, and a predictive biomarker will tell you that the tumor will respond to a chemotherapeutic agent. So let me show you how this pans out and why this is really useful. Because first of all, predisposition biomarkers can help us identify patients at risk and handle them differently. So, and I'll give you these examples later, somebody that comes in with blood in the urine, most of those causes, depending on the predisposition biomarkers, but if you take all the population together, everybody that comes to a family doctor's office with blood in the urine, most people do not have bladder cancer, but some people do. So if you take at one end of the spectrum a 22-year-old female that doesn't smoke, and she has blood in the urine, and at the other end of the spectrum, a 67-year-old male that smoked for 50 years, and the blood is very, very intense in the urine, those two patients are very different because their risk of having bladder cancer from that same symptom, which is blood in the urine, is 100 to 1. So the 22-year-old woman will not likely have bladder cancer, but the 67-year-old man will. So that's a classic prognostic, how predisposition biomarkers, in this case, age, smoking status, and the level of bleeding is useful. Disease aggressiveness can be used as follows. So you have patients with bladder cancer. You have patients that have high risk by the prognostic marker. Let's say they have high stage. These patients have high stage, so we then test them with a predictive biomarkers to say, let's just say that they have a T1 grade 3 aggressive non-muscle invasive bladder cancer. We test them basically for a response to intravesical therapy like mitomycin or BCG. And look what happens here if we test. So in this group, we do testing. In this group, we don't do testing. So if you test and the test tells you, okay, these 3 patients are not going to respond, and these patients, the rest of them will respond, whereas if you don't test, you treat everybody, look at the difference in the response rate. What you've done by doing this is that you've taken these patients and you have not exposed them to the toxic effects of ineffective therapy. So that's really a big advance. And of course, if we have different drugs, we can basically look at this group and see if we can treat them with different things that will be effective. So that's the value of these tests. This is a slide that tells you in, perhaps more complicated form, what are the types of tests. But don't let these pictures scare you, because I'll just go through them very simply. So the key to personalized medicine is that you really want to evaluate the host and the cancer. It's really important because the host response to a cancer is one of the determining factors of how the patient is going to do. We know more and more about this. For example, the immune system has a lot to do with how we respond to cancer, and so it's very important to look at the host. And the way we do that is we look at SNPs, which I'll show you in a minute what they are exactly, but these are pieces of DNA that are different among people. And so the tumor, of course, can be looked at by a variety of things. We looked at mutations, so these are DNA coding sequences, basically, where they're changed compared to the normal. So the gene, instead of being normal, the gene is now altered, and that altered gene does bad things. And FISH is something that you may have heard of in your own experience. It's something that is called, the trade name is Eurovision, and some of you may have had that on your urine samples. And that's basically a test that tells you if the chromosomes are not okay in the urine sample. And then there's microarray, which is a tool that looks at the genes that are being turned on and off in the cancer. And immunohistochemistry is something that every pathology lab uses, and that's a test that looks, again, at genes that are going up and down abnormally. So the upshot of all this, though, think of it, is that you have multiple ways, multiple facets to look at the cancer at the genetic level, and you use those multiple facets to develop prognostic and predictive markers that will predict tumor recurrence and how we should be treating the patient. So these are the three really challenges in taking care of bladder cancer patients today. Improving the primary diagnosis, so basically predicting individuals that are high risk to develop bladder cancer. Optimize the surveillance. As you know, patients that don't have muscle-invasive disease have to have repeated evaluations with cystoscopy, etc. So basically, we have to find new ways to detect these things when they recur and minimize the morbidity for recurrent procedures. And importantly, one of the big challenges is to try to reduce the mortality that's associated with muscle-invasive disease, which takes far too many lives. So I'm going to show you examples of how molecular biology and molecular genetics can actually help with these three topics. So I'm going to show you about a tool called GWAS, for short, Genomewide Association, that predicts patients at risk. Tools that are from our own laboratory and others that can basically determine disease aggressiveness by looking at mutations in specific genes and a 20-gene predictor. And predictive markers from our own lab that actually are the first in the world and the basis for a national trial that will predict which patients will respond to chemotherapy. So let me tell you about the Genome-Wide Association, GWAS. So if you look at the person sitting next to you, their DNA, believe it or not, is 99.9% identical to yours, but I will bet you, unless there is a pair of identical twins in the room, they're not going to be looking anything like you. And the reason for that is because we have these things called single nucleotide polymorphisms, or SNPs. These are, if you will, spelling errors that have evolved over many thousands of years and basically make us all slightly different. But the importance of this is that we can use them scientifically, and by comparing patients with cancer and patients that don't have cancer, in very large studies, we can look at these SNPs and see if these SNPs, if there are specific SNPs that are associated with risk of cancer, okay? And that's what these genome-wide association studies are. So in essence, patients with cancer, non-patients, we do these, we evaluate these millions of SNPs in their tumor, in their normal cells. So these are swabs of the buccal mucosa, similar to forensic analysis, basically. And we look at their DNA, and this is what you get. So this is a compilation that the National Institutes of Health has on their website, and what this is basically are the SNPs that are found to be different between tumor patients with cancer versus patients that don't have cancer. And you could see here the most important box, and these are studies parenthetically that have involved an enormous number of patients and controls. Look at these numbers. In the United States, 5,000 patients with cancer, 38,000 controls, 8,000 with 48,000 controls. So basically here, you have, this is the most important column. This is the risk, if you will. So if you have this SNP here, your risk of getting bladder cancer is basically 1.47-fold higher than somebody that doesn't have it. Now, if you look at the rest of these, the risk is very small comparatively, and so the individual risk is perhaps not as determinant by this, but this is just the beginning. We're just beginning to do these studies, and we're going to hopefully get better predictive ability because when time, in what will happen is, and I'll show you this with the last slide in the talk, is that we'll be able to predict these things very early on, even after birth, soon after birth. So the other thing I wanted to show you is, and this is the introduction to this, is we know that, and this has been known for quite a few years, that bladder cancer evolves basically according to two different molecular pathways, okay? So what that means is that when the normal when the normal cells become transformed they become malignant, they can go along the pathway where most of the time the cancer is going to remain on the non-invasive, or go to this other pathway where the cancer becomes invasive. And we know there are different genes that regulate if the cancer goes one way or the other. The good news is that by virtue of knowing this molecular information, we can actually help patients, and I'll show you how that works. I'm going to show you by example of this particular gene called FGFR3. And this is actually a very interesting gene because it wasn't discovered in bladder cancer. It was actually discovered in achondroplasia, which is a disease where the patients have short stature, and I'm sure you've seen patients that have this entity. But people have subsequently identified the same mutation in FGFR3 actually occurs in bladder cancer. And what this does, essentially, is when the gene is mutated, the receptor, which is this gene forms a receptor in the cell, this receptor fires too much uncontrollably. In the case of a normal baby, basically firing this receptor limits bone growth and hence the short stature. In cancer, basically firing the receptor makes the cells grow. So people have shown, and there are several studies here, and everything I'm talking about is in your handout, by the way. There are several studies here that showed, interestingly enough, that if you have a mutation of this gene, actually you're going to do better. So unlike many other genes that we deal with, when the mutation means it's not good, this is actually a good thing to have if you have a mutation. Because if you have a mutation, you have a better prognosis than people that don't have the mutation. And again, this is within the realm of patients that have non-muscle invasive disease. So that's a useful thing because one of the things that we could use this for is not only prognostication, so telling the person that they're going to do better, but also we can follow patients non-invasively. So in theory. And so this pie chart, if you focus on this is a pie chart showing all the mutations in tumors at the beginning and recurrent tumors. Okay? So these are patients that have been looked at for mutations, and these are the same patients, some of which have had a recurrence. And if you look at this, even from the back of the room, you could tell the pie charts are the same. And that's a really important finding because when you think about it, if the recurrent tumor is different than the original tumor, then you can't follow somebody with the same analysis of mutation that you had on the primary tumor. So in other words, if somebody comes in with an FGFR3 mutation, then if you follow that person, watching in the urine if that mutation shows up, that's useful, but the assumption is that the recurrent tumor has the same mutation. If the recurrent tumor has a different mutation, then following with FGFR3 is not going to work because you're going to miss the tumor. So you're still going to have to do the conventional things, cystoscopy and other things. So this is really was an important study and lays the intellectual framework for basically following patients with fewer cystoscopies. Similarly, from the same study, if you focus on these two pie charts, I think the really interesting thing here is that it also showed us that patients that have high-grade non-muscle invasive tumors have similar mutational spectra to patients that have a muscle invasive cancer. So what that tells you is that, in fact, these T1 grade 3 tumors, although we call them, they are superficial or non-muscle invasive, basically they're fairly serious things that we can't take lightly, so we need to be very aggressive with them because they have, if you will, the molecular wherewithal or the molecular machinery to actually go into the muscle. So we really need to be aggressive with them. Another big challenge in the field is how do we improve the outcome of patients that have muscle-invasive disease? And we know from very well-done studies that neoadjuvant chemotherapy, so this is chemotherapy before having your bladder removed, benefits patients. But here's the problem. It only benefits a few patients, the bottom line. So it increases the overall survival from 45% to 50%, and because of that, it has not been adopted in the community, and people have shown this. It's only been adopted maybe 2 to 3 or 4%, despite very large studies showing that there's benefit. The problem with it is that we do not know, and I'll show you that we've actually recently discovered a solution, but up to now, we really didn't know which patients actually comprise the 5%, because the community has not adopted this, because the feeling among urologists and medical oncologists in the community is, despite the benefit, is that we're over-treating pretty much everybody, and we're only benefiting a few. So how can we fix this? Well, there are two ways. If you think about it, we can actually use prognostic markers to tell us which patients really need the treatment by virtue of having an aggressive cancer, and predictive markers, which are markers that will tell us, among those that have aggressive cancers, how many patients will actually respond to the chemotherapy. So this is a tool that was published recently from our lab that basically has developed and then validated a 20-gene marker that we can do on the cancer. And what this gene marker does, for the first time, it's able to predict the likelihood of the patient having lymph node metastasis at the time of cystectomy. And that's useful because if you know that ahead of time, you'll be a lot more likely to treat the patient with neoadjuvant chemotherapy, because I don't think anybody will argue that if you have lymph node positive disease, you would be a candidate for chemotherapy. So this test is in the process of being converted to a format that can be used on patients in a routine way. So I'm pretty excited about that, and that's going to be deployed nationally through likely a biomarker company. The other thing that we need to do is to predict which patients actually respond to chemotherapy. And this is basically a tool that we discovered in our lab called the Coxn System. And this is a tool that has universal applicability to any cancer, but I'm showing you examples here on bladder cancer. What this tool does, unlike anything that was before it, is able to develop biomarkers of response to different drugs based on tumor characteristics and cell lines that we test in vitro in the lab. So this is basically a demonstration that it can predict outcomes in patients that have been treated with neoadjuvant chemotherapy, and this is actually the basis of a trial that Tom Flake, who's going to be speaking to you later in the afternoon, and my colleague at University of Colorado, is the principal investigator on a trial that basically is going to test this system in patients in the United States. So we're very happy that this trial has been adopted by the community at the national level. We just came back from a meeting 2 weeks ago, a week and a half ago, where this was adopted by the National Cancer Institute. So that's very exciting, but there are challenges. And I broached some of them at the beginning about the application and of personalized medicine. Unfortunately, many of the studies that have been done are not validated. So they discover the biomarker, but they don't test it. Both of the things that I showed you have been validated, so that's why we're moving on into clinical use or clinical trial. So we also need to study the benefit of these technologies in terms of gene-guided management. So we have to show ultimately, and that's what Tom's trial is going to do, is once we use these tools to tell us which patients can benefit from the chemotherapy, if in fact they work. In other words, are we going to improve the survival of patients if we treat them using these molecular guided tools? And we have regulatory hurdles, and we need to educate our colleagues in the community, and we need to educate our patients. And this is a forum such as this to know what is coming down the pipeline and what things could potentially be of benefit to you, because you're the ones that really count. But I'm an optimist. That's why I do this. And I dream about this stuff all the time. And so I see this as the future. So you have a baby, and the baby is going to get molecularly profiled at the genetic level, and you're going to see a whole bunch of things. I've made some of this stuff up, of course, to make the point. You're going to know that we're going to test for genes for intelligence, because we know it's not all genetic, but I made it up anyway. The risk for heart disease, risk for bladder cancer, and you know, if the baby has the risk for heart disease, we're going to start statins like Lipitor and other things earlier on than we would normally. If they're smart, we're going to encourage them to go to, take all the high-powered classes in school, and maybe even encourage them to be a urologist. Okay, yeah. So if they're at high risk for bladder cancer, we're going to warn them about smoking, and we're also going to tell them to avoid professions where they get exposed to chemical carcinogens. Not that that's good for anybody, but especially for this person. So let's just say then, unfortunately, despite all this, the person gets bladder cancer at 46, and he never smoked, and he became a urologist, but he gets cancer anyway. And so then we jump in and do tumor and host profiling, just like I showed you on one of those slides. And so it turns out, unfortunately, that he has aggressive cancer, but we use the information that we got here from the host and new molecular profiling and basically have molecular guided therapy. So we understand what his cancer biology is, and we basically have a designer drug for the molecular lesion that he has. And then we have molecular guided follow-up. So we treat him, and then we have this is a biosensor that the person is wearing that can sense cancer cells in the circulation. And we actually, this sounds like sci-fi, but our laboratory, in combination with laboratories at UC Boulder and the School of Mines, basically are developing such a device that will actually interrogate on a high throughput way cells in the urine and identify if they're cancer cells and actually if they're sensitive to treatment. So we haven't gotten it down to a level of having a bracelet, but I think the point is it's a microchip, much as like a microprocessor in a computer that actually analyzes cells that flow through it with various things like lasers and things like this. So this is not that far off, believe it or not. But the bottom line is that I see this as the future, and I see basically the conversion of cancer into a chronic disease, much like a hypertension or diabetes, where people no longer need to be frightened, and we just have to do this in order to convert it to a chronic disease and keep people alive. So with that, I'd like to thank you for your attention. I hope this was helpful and not too technical, but I think this is really the future, and I think once you become familiar and you hear more of these talks, I think it's going to be increasingly sort of familiar to you. Thank you.